Welcome to Lesson 6, Part 2, Medications for Diabetes Mellitus. I'm going to focus on diabetes mellitus type 2. Your reading took you through the other two types, type 1s, who of course need insulin medication, and type 1.5s, or the latent autoimmune diabetics of adulthood, who probably are going to mostly need insulin and who often fail oral or other non-insulin diabetic medications. So I'm going to focus on the DM2s. I want to make one comment. Again, this is a flashback to your pathophys, that we treat diabetes similar to hypertension, not so much for its current effects on the body, although a high blood sugar or a very low blood sugar does make a patient feel very lousy, so we do want to make them feel better, but it's for the long-term effects, and it's mostly to do with the vasculature, both micro and macro vasculature of the body, in the eyes, the heart, the kidneys, and the peripheral vascular circulation. So we're trying to prevent those long-term effects. This is a great slide to take as a reference, and it helps us decide what we're going to do with this type 2 diabetic who enters our practice and they have their hemoglobin A1C, which is the measurement of glucose over a long period of time, the life of a hemoglobin molecule, so like 3 to 4 months time, and their A1C is our target lab that we use to monitor therapy. If they walk in the door with an A1C of under 7.5, we can consider just one drug. If they are 7.5 to 9, we consider starting them with dual or triple therapy. If they're over 9 and they have symptoms, we go straight to insulin. And those symptoms are things like, symptoms and signs I should say, but symptoms are things like trouble with damage to eyes or kidneys, or that's signs, or symptoms even of polydipsia, polyphagia. We would go ahead to insulin, and we also may, if they're not symptomatic but still high, and I see a lot of that with type 2 diabetics, we can go ahead to dual or triple therapy initially. This gives us a great snapshot of kind of the good, bad, and the awful about the various drugs that are on the market. And you have to go into the guideline to see which drug is represented by the abbreviation at the top. This is metformin, the MET drug, and that is the first line drug in both your single therapy, dual therapy, or triple therapy. Metformin is always there in dual or triple therapy, as you recall from the prior slide. And yes, it does have some problems. It has some contraindications with chronic kidney disease, and we want to be careful. So this helps us. There are very few drugs that have kind of a neutral effect, and thus, but because of some of the other positive effects of these other drugs, we will consider them first line versus second line. Great resource for your hip pocket for clinical later on. This is an older slide that walks you through and just gives you that snapshot and a sense of how the drugs work at different places and work in different ways. And it helps me kind of think of, okay, if I'm already giving someone a biguanide, which works at the liver and in the muscle as well as in the gut, I'm going to kind of stay, maybe move to another area, maybe a sulfonylurea for my second drug, or over here to one of these drugs, so that I can get some balancing of effect over various things. I'll make a comment too about the drugs that work at the pancreas. Again, they are basically stimulating the pancreas to put out more insulin. And if the pancreas starts to die off, as is true later in diabetes, we can't flog it any further. These drugs are not going to work, of course. I also want to caution you that drugs that work to make more insulin get secreted, of course, are going to be higher risk for hypoglycemia or low sugar effect, which can be life-threatening. So we start with metformin. Let's start here with MET. Again, this is a quote out of rxlist.com. Its mechanism of action is different than the other oral anti-hyperglycemic agents. It decreases the hepatic glucose production, decreases intestinal absorption of glucose, and it increases peripheral glucose uptake and utilization. I'm not going to dig into the actual pharmacologic chemical or cellular effect of these drugs. I'm really going to focus on the clinical effects because there are so many of them. The new kids on the block, one of the new kids on the block is the Siglets. And again, the SGLT2 works in the kidney to reabsorb glucose in normal circumstances. These drugs inhibit that transporter system, and therefore there is more glucose that is excreted in the urine, taken out of the body, and gotten rid of. You don't even have to deal with it anymore. Of course, this means that there is a urine sitting in the bladder of a diabetic, which is quite sweet, if you will, or full of sugar. And when you think about it, it's just a beautiful medium for just a stray little E. coli germ to come along and plant itself and cause an infection or a cystitis. So it is one of the cautions about this drug. It's such a new drug. In my personal experience, not used much because, of course, it's expensive. It's not considered first or second line. And so I think you'll see the endocrinologist using it on a regular basis, trying it out. I don't know where we're going to go with it and whether it will survive post-marketing adverse events reporting and become a drug of choice later on. For your homework, you've got this drug plus 4 others. You are going to be split into 5 groups by your alphabetically, and you're going to sell your drug like a drug representative would. Again, focus your comments on the clinical effects or clinical mechanisms of action of these drugs and think about how they work at different organs of the body, both for effect and also side effect or adverse reactions. This is a slide that I want to emphasize a little bit because one of the things you do when we give patients these drugs and we check them every 3 months if they're not well controlled, every 6 months if they're getting better control. So diabetics need to be checked on a regular basis, and we're monitoring their hemoglobin A1C or their A1C levels. And we're going to look at very stringent control with our diabetics under 6.5 or even 6 in some cases. We try to keep our young type 1 diabetics very tightly controlled best we can without hurting them versus less stringent control, maybe saying to an older patient or a patient with multiple comorbidities or a person who has trouble with hypoglycemic reactions, we may say, listen, putting you into that situation isn't good. We're going to have you try to keep your A1C under 7.5 or 8 even, and we're not going to get as worried. We call this letting them be a little more sweet and so forth. So all of these things come into play as we decide or help the person decide where their blood sugar is going to be kept. It also is the place that we make a decision in terms of how low we're going to ask them to do their home monitoring, how low they want their fasting sugars or their prandial, their before meal sugars to be. Usually we say between 100 and 120, and we might stretch that 120 a little bit for our older, more debilitated patient and say, you know what, your morning fasting blood sugar doesn't have to be 100. You can keep it at 120 to 140 and it's okay. The only one I'd make a comment about is I think those with less resources and support systems probably need more help in getting their glycemic control better because, of course, the better that control is, the better they're going to function. They'll be able to be more employable and thus get better resources. But that's another story. So there's always insulin. It always works. That's one message I want you to walk away with from this course. Insulin always works. It's the natural part of our body. Of course, we don't any longer manufacture insulin from animal organs, but we used to. It is a natural occurring substance. We used to make it from pork, but nowadays it's mostly made synthetically, and we have different forms of insulin. We have long-acting or basal insulin, which include our glargine, such as Lantus, and there is also a more concentrated form of that, which you will hear about in the insulin tutorial. And then the Dedamirs or Levemir being an example of that. So these are long-acting basals. We have intermediate acting or NPH insulins. We have short acting, regular insulin, and very rapid acting, such as Humalog, Novolog, and Apidra brands. You want to really know the onset, peak, and duration of these all. Here's a great slide to take home and think about and to study. This gives us the onset, the peak, and the duration of each of the commonly prescribed insulins. And it's very helpful to kind of see, and if you kind of flip the graph upside down, you'll think about how low the blood sugar would go when you give any one of these insulins. You're going to have low sugars very quickly, of course, with the rapid acting, less so with the short acting, and hardly at all with the basal or glargine or detamir insulins, which are long acting. There are insulin mixtures that take advantage of kind of both parts of the picture and mix some regular and NPH insulin. These are older insulins. They used to be used as our basal. This is how they were dosed. And I still have some patients who swear by it, keep a beautiful A1C using these regimens. They are very careful. These are people who eat the same things every day at every time, and their life is very regimented. The good news about these insulins is they're very inexpensive, and I think they even can actually be purchased over the counter, behind the counter, as can regular insulin. And some of my old diabetics also just use regular insulin every once in a while when they get stuck. It's not a great answer, but it does work. You just have to time your meals a little bit differently. So, a good answer for a person who has low income and doesn't have insurance or prescription assistance. So for these 4 patients, just really quickly, our diabetic type 1, we really aren't talking about today, but they're of course going to be on insulin. They're going to be on a basal, plus they're going to be on 3 or 4 times a day, short acting, to be taken to cover meals or to cover hyperglycemia. And you can look at your insulin tutorial to talk about that. We have a diabetic who's fairly young. His blood sugar at diagnosis is very high. He's probably going to have an A1C above 9. He may or may not be symptomatic, but we may possibly start him right away on insulin because he's young. We want to be aggressive. We want to get on it. A 65-year-old female with type 2. She's not at goal. She's got 3 oral medications. She doesn't really want a carb count to do mealtime insulins and adjust insulins. She'd be a great candidate for just adding a basal to her oral meds. And that's done all the time and very effectively. It just ramps that A1C down just enough, and they still stay on their oral meds. A 48-year-old who failed with metformin and glipizide probably is a LADA or a type 1.5, needs insulin regimen that's cost effective. They may do well with those mixed insulins, or we would get them on prescription assistance and put them on a basal plus a mealtime short-acting insulin to cover carbs. In your calculation homework, you're going to be creating a basal and meal coverage prescription, and you can look at the tutorial to get more advice about how to do that. This is the end of this slide set. I look forward to seeing you in the tutorial and online. Thank you.